to this gathering how important cervical assessment is for a patient of carcinoma endometrium. So it is very important that you should put in a speculum and rule out that the cause of the abnormal bleeding, whether it is postmenopausal or otherwise, is not the cervix, not the vulva, and not the vagina, and that the bleed that we are getting is essentially from the endometrium. Imaging, endometrial biopsy, and molecular diagnostics. Let us address all of these one by one. Starting with imaging, most of the patients, they undergo a TDS or a TAS, that is a transabdominal scan or a transvaginal scan. Many undergo CCT, MRI, and PET-CT. So let us see what each one has for us. Transvaginal ultrasound is the first imaging step in patients with abnormal uterine bleeding. According to the ESMO, and ESTO, the mandatory preoperative workup of uterine cancer should include a transvaginal or a transrectal scan, in addition to a pelvic exam, of course. Cutoff value of 4 to 5 mm is indicative of carcinoma in postmenopausal women with 96% sensitivity and 61% accuracy on meta-analysis. So, expert ultrasound distinguishes between polyps. I'll talk about that later. So, when it comes to endometrial thickness, if a lady comes to you with an endometrial thickness of 4 mm and only one episode of postmenopausal bleeding, the chances of her having hyperplasia or endometrial cancer is less than 1%. However, if this is increased to 10 mm and multiple episodes of postmenopausal bleeding, the chances of her having endometrial cancer is more than 10%. So that is how the algorithm goes, and that is what you have to keep in mind. Expert ultrasound distinguishes between polyps with low and high risk of malignancy. Benign polyps, they have a smooth surface, single pedicle, and malignant polyps, they have an irregular surface and multiple feeding vessels. Now we find that in asymptomatic premenopausal women, up to 44% of them can be having polyps. And amongst asymptomatic postmenopausal women, up to 34% of them can be having polyps. Now for the premenopausal women, the chance of there being malignancy in these polyps is only about 1.7%. But the chance of malignancy for postmenopausal women having asymptomatic polyps can be as high as 4 to 7%. So it is important to know these statistics so that you know what you are dealing with. This is just an image to show you. Is there a pointer somewhere? Yes. Yeah, this is good. Okay, so this is the sagittal. Yeah. Okay, so these are sagittal and coronal sections. You can see very fine endometrium, very nicely. You can see that it is absolutely clear. And whereas here you see it's all distorted, and there are some subendometrial cystic spaces. So obviously this is the C and D are the suspicious ones, and A and B are what is a normal picture. Same thing if we add color Doppler to it, this obviously is something abnormal. You see increased vascularity, so this might be either a hyperplasia or a carcinoma. We would have to find out about that. The advantages of PVS, of course, are that it is reproducible, dynamic, and non-invasive. High resolution transvaginal probes, color Doppler, 3D volume acquisitions, and all of this make it possible to reach the diagnostic accuracy of MRI in assessing the tumor size, biometric invasion, as well as cervical stromal involvement. So what is the next modality of imaging? Next is MRI. NCCN guidelines, they define the role of pelvic MRI in the initial workup of endometrial carcinoma to assess the local disease extent. As per Boyle et al., the sensitivity and specificity of MRI for assessment of biometric invasion was 75% and 73% respectively, and the overall accuracy was about 75%. Sensitivity of MRI is poor, that is about 37.5%, 50% respectively, in predicting extrauterine extension and in assessing cervical stromal invasion of the carcinoma of the endometrium. Next important thing is the lymph node metastasis. So Arian et al., they reported that for diffusion weighted MRI, it had a sensitivity of up to 80.6% and specificity of up to 100% for predicting lymph node involvement, and overall accuracy was 87.5% in discriminating between a metastatic and a non-metastatic pattern. So this is just another image to show you. Yes, see, again you have a very nice normal endometrium, and this is the heart-shaped picture, again of the sagittal section, coronal section, and you can see all this is normal endometrium. And this is an image of a very obviously abnormal endometrium. This is a MRI, this is a non-contrast MRI, and this is a contrast MRI. And you can see even in the non-contrast MRI, you can see that the endometrial growth is invading the myometrium. And here, of course, since it is a contrast MRI, you can very nicely delineate the margins, and then you are able to say, is it invading less than half of the myometrium or more than half of the myometrium. So these are the kind of images you can get on MRI, which are very helpful to you in deciding what kind of surgery and what is the extent of surgery that you need to do for this patient. Lymph nodes again are very nice picturized away. You can see there's a lymph node here, there's a lymph node here, lymph node. So depending on the imaging, you can make up your mind. Next, of course, so many patients would come to us with the PET-CT images. We normally, as a routine, do not do a PET scan for patients who are suspected of having carcinoma endometrium. It is highly specific in detecting metastatic nodes, however. So with PET MRI, you are able to detect retroperitoneal lymph nodes, which you might not be able to do with other imaging, because for simple reasons that you might have just omitted it. When you are asking the patient to get an MRI done for C endometrium, you would mostly tell them to get an MRI of the pelvic MRI scan done, isn't it? So you just might miss retroperitoneal nodes, and especially if you do not have the grade of the tumor. So detection rate is only 12% in metastatic lesions measuring 4 mm or less, and 100% sensitivity when the lesion is 10 mm or longer. In advanced stage or larger. In advanced stages, it helps in detecting metastatic deposits locally, momentum and distance spread. Now we have finished examining a patient. We have finished imaging a patient. Are we still sure that we are dealing with a patient of carcinoma endometrium? No. We are not sure because we do not have a tissue diagnosis. Now let us see how can we obtain a tissue diagnosis for a patient of carcinoma endometrium. First thing is PIPIL, that is an office procedure. Endometrial sampling is highly sensitive for detection of endometrial cancer, with detection rate of 99.6% in postmenopausal and 91% for premenopausal women. There is an 81% accuracy for detecting atypical endometrial hyperplasia. Advantages that it can be performed without anesthesia, expertise is not required, and cost of course is much lower. However, we have to remember that there is limited capacity to identify polyps, and there is failure of doing an adequate sample, and false negative rate can be as high as 10%. If you are not able to do a PIPIL, the next thing that you resort to is a dilatation and curettage. So when office endometrial sampling is not possible, for example, there is cervical stenosis, or sometimes the patient is just simply uncooperative, we want to do a DNC under anesthesia. Studies have shown that PIPIL biopsy and DNC have comparable accuracy in detection of various endometrial abnormalities. However, in 60% of the cases, histological sample is obtained from less than half of the uterine cavity curettage. Curettage is known to miss 50 to 85% of focal intracavitary pathology. So if you have a small pathology, say at the conval ends, or maybe somewhere stuck in the fundus, or maybe something just close to the internal os, you just might miss it, even if you do a DNC. So then what is superior to that? A hysteroscopy and cavity biopsy. Superior to blind curettage in obtaining adequate endometrial samples for histological examination. Direct visualization and high magnification will help in distinguishing between normal and abnormal endometrium. So you don't require any training for this. Merely by looking at it, you can figure out that yes, this hypervascular area, this flat area, what is normal, what is abnormal, and you can actually take a biopsy from an abnormal area. The overall success rate of diagnostic cystoscopy is 95 to 97%. Neither disease-free nor OS nor recurrence rate they are affected by this procedure. So all this halabala about that you are dilating the uterine cavity with saline, so you might cause a peritoneal spill, and all that does not affect survival at all in a case of endometrial cancer. As it is, we have seen that in the present staging, FIGO staging of endometrial cancer, positive peritoneal fluid cytology is no longer a consideration. So, just to summarize what I have said so far, a patient comes to you with postmenopausal bleeding, you do a transvaginal ultrasound scan, right? And then you assess the endometrial thickness. If it is less than 5 mm, you do a speculum examination, everything is normal, no biopsy is required. You just reassure the patient and send it off. I've already told you what the implication is if there is only a single episode of postmenopausal bleeding. If the endometrial thickness is more than 5 mm, but there is a regular contour, you can do an endometrial biopsy. With inadequate sample, again, probably it's just a endometritis or something, wherein you do not get an adequate sample in such cases. So again, low risk, you can reassure. If it is high risk or an abnormal ultrasound, you send the patient for cystoscopic biopsy. Okay? And if the patient, even after all this, comes to you with the repeated episodes of postmenopausal bleeding, like I've already explained to you how important the number of episodes of postmenopausal bleeding are. So in that event, again, you would resort to the cystoscopy and a DNC. If the endometrial thickness is more than 5 mm, there are irregularities, polyps, and all that, it's always best to do a cystoscopy plus an endometrial biopsy, and whatever the result may be, you act accordingly. So I think that simplifies things. And now, you have your biopsy. Is it enough? I've already spoken with the grade, this, that, and the other, but is it enough? Let us see. To recapitulate, once again, there are two types of endometrial cancers, type 1, type 2, I have already spoken, and what they have the different kind of genetic alterations. I think I will not go into all that because that becomes a little difficult. But what is the importance of biomarkers as of now? Now, in the POTEC trial, what did they find? That you and me, we might not agree on the morphology. That becomes difficult. How am I going to treat the patient then? They found that there is an inter-observer disagreement on histopathology for the histological type up as high as 34%, for stromal invasion as high as 27%, and for grade as high as 19%. So, to do away with this, we have brought in these biomarkers. So there has been an evolution in the field of cancer from histological based classifications to more recently defining tumors by molecular features. So we have these two types of, in fact we have several, but I have brought here only two types of molecular classification. One is the Cancer Genome Atlas, and second is the proactive molecular risk classifier for endometrial cancer, that is PROMS. I'll briefly tell you about both of them. ECGA identifies 4 subtypes. You have the core ultramutated, about 6 to 10% of endometrial cancers fall in that. You have the MMR tumors, about 23 to 30% fall in that. That is a mismatch of their gene. You have the copy number high, that is the P53 mutations. About 10 to 12% fall in that. And of course, you have the copy number low or cancers which have none of these mutations. And more than 40% in fact fall in this group. Addressing each one by one, polymutations. Now 10% of all endometrial cancers will be polymutated. They will have an exceptionally good prognosis. They will be low stage, high grade, and they mostly occur in young patients. That means that for all high grade carcinomas, if you have done a pole mutation and if they are pole mutant, then even if the cancer is high grade, these patients will do well. Even if the cancer is high grade, these patients do not require any adjuvant therapy. Right? So this is useful to avoid aggressive treatment in approximately 10% of these patients, and in the POTEC trial it was seen that none of these patients who were pole mutated, they had a recurrence. Whereas 30.9% of patients who were not pole mutated were pole while they had recurrence. Next one important is the mismatched pair genes. 30% of all endometrial cancers, they have this mismatched pair genes. They are generally high grade. In them, LDSI is positive, and 3% of them will also have Lynch syndrome. Implications are that they respond very well to radiation. There is no response to additional chemotherapy, so please don't give them chemotherapy. And recurrence and advanced if they do recur, advanced immunotherapy can be given in these patients. So if you already on your biopsy specimen, if you are able to say that yes, this patient expresses MMR, so definitely you will do a more extensive surgery. The P53 mutation, 10 to 12% of endometrial cancers, they are P53 mutated. They are generally high grade, serous carcinosarcomas. There will be increased amount of metastasis in them, so they will behave like serous carcinomas. So they have to be treated like serous carcinomas only. And how do we treat serous carcinomas? We do a full staging laparoscopy in all serous carcinomas of the endometrium. For endometrioid carcinomas, we just do a THBSO, isn't it? But for the serous carcinoma, we do a full staging laparoscopy. Implications are there is good response to chemotherapy, and you can also give them tamoxifen. Next is the proactive molecular risk classifier. That was the TCGA, and this is another subtype wherein they identify NMR, OE, P53 abnormal, and P53 wild type. So P53 abnormal is of course, like I've said before, most aggressive, and MMR are the second most aggressive. OE mutated have excellent prognosis, and P53 wild type, they generally will be low grade, low stage, and endometrioid in 99% of the cases. So if you have nothing else in your center, you are not sitting in Delhi, Bombay, or maybe one of the capital of any of the states, and you have none of all this, you will definitely be able to persuade your pathologist to do at least a P53 or a MMR. Yes. Because all this can be done on IHC, and this can be done on biopsy specimens. So before you start doing any surgery for endometrial cancer, if you have a P53 or MMR, you know what you have to do for your patient. And if they are not P53 mutated, you can tell your patient that even if you have a grade 2 or a grade 3 carcinoma, you are going to be doing well. Surgical implications. The type of surgical approach is planned based on the preoperative impression of stage, which is based on pre-treatment evaluation. Minimally invasive approaches in endometrial cancer staging result in lower rates of peri and post-operative complications than laparotomy without negatively impacting oncological outcomes. GLH with BSO, robotic hysterectomy with or without bilateral PLME, and all of that is optional. You are going to, once you have this preoperative diagnosis, you are going to decide on all of this. Next important thing is your sentinel lymph node biopsy. Now this can be considered in low risk and intermediate risk endometrial cancers. We have so many trials which have given their result, and